Welcome to session 3, famous session 3. And I just want to follow up. I didn't mention to Simeon, I don't know if you guys saw the headline coming out of the UK a couple days ago, this big study that said sleep deprivation is the single biggest health threat, and the biggest way to save money is to get everybody in the UK to sleep longer. And I just want to share the results with you guys of a study I've been conducting for 25 years that they could totally benefit from, which is if you say the word practice expense, people go to sleep. So I feel like we have a lot we could go where with that. And I just want you guys to prove me wrong. So we're going to talk now. This is called the quote-unquote research session or technical session. And these three are bravely going to talk us through some research related to the physician fee schedule. Joe's going to talk to us about prices and why they matter. And then Steve's going to talk about work and some research that he, with others, have done about that. And then Peter Hussey, bravely from RAND, is going to talk about practice expense and the challenge we all face, no fault of Peter's, is to not all fall asleep. And I'm telling you, it's hard. But we are missing Antoine. And, oh, hi. He's sitting up here, too. You want to come sit up with us? Yeah. He didn't want us to watch him sleep. He was going to sleep in private. We've invited him to join us on this sort of technical thing, to add anything he might want on sort of the more technical aspects of what they do and on their fee schedule, and also possibly to respond to some of the issues and topics that get raised here. He will say a lot or a little as he is moved to by the time we get to that. You can tell that part hasn't been as planned as the rest. So first we have Joe Newhouse, who is well known to many of us here. He's a Harvard professor with a long title, but I'm not going to say, sorry. And so many accolades that you just have to read them. But the one that's salient, besides his work as a health economist, is that for several years, he was the vice chair of MedPAC in the 90s. And there's a lot of ex-MedPAC people here one way or another. A second, we're going to hear, as I said, he's going to talk about prices and why they matter, why we care about them, and evidence about that. Steve Zuckerman is the senior fellow and co-director of the Health Policy Center at Urban. You've already saw him. He moderated the previous panel, but he did not introduce himself to you then. And he will talk about work. And then Peter Hussey, who is the senior policy researcher at RAND and the director of their health services delivery system program, and a professor at the RAND Graduate School. And he's going to talk, as I mentioned, about practice expense, and you guys are going to be admirably attentive. And then finally, we'll hear some more from our lunchtime speaker about how this stuff plays out in Quebec. So I'm going to ask Joe to start, and I know he has slides here. Thanks.
So I wondered about scheduling a technical session right after lunch. When I was on MedPAC, the staff always used to see who drew the short straw by who would present right after lunch, because the commissioners would be falling asleep. So let me dive into it. I'm going to follow the dictum of the person, I think, who said they would put I think it was Victor, put their conclusions up front. So in case you do fall asleep, you will at least have seen them. As Katie said, let's talk about some evidence on how the levels of fees matter, talk about why there are kind of inherent problems in a pure fee-for-service system, and then where I would head. Bear with me. If you've taken economics, this should be somewhat familiar. If you haven't, all it says is if you change fee levels, let's say increase them, we don't really know whether, a priori, whether that would increase services or decrease services. Somebody said they'd taken Economics 101 and if you decrease them, it should decrease services, but I'm about to show you that isn't so, at least empirically. So this comes from PPRC. Maybe Paul and Katie and Lauren, if she's still here, will recognize it. This was actually from the implementation of the RBRVS in 1992, and the PPRC staff looked at what happened to services where the unit of observation was a state-specialty. So the slide says like cardiologists in California. And what they found was there was, in fact, a negative relation. If fees, fees went up for, as was said this morning, for the E&M services, tended to go down for procedures. Things that went down, there was more of after the fact. So if fees went down about 3%, the estimate here is that there was about a 1% offset. And this, unlike most of government scoring, actually became enshrined in the CMS actuaries' estimates of what proposed legislation would do for Medicare spending. Okay. Second study, 2005, Medicare makes a really large change in how it pays for cancer chemotherapy. Markups on cancer chemotherapy by the oncologists were roughly half their income, and their income about that time was ballpark around $400,000, $500,000 a year. So you see the red line there is a fall in carboplatin, and the yellow line's a fall in paclitaxel. And so these fees went down by on the order of a factor of 10, from over $2,000 to down under $500. So big change in income. We looked at what happened with lung cancer patients. Roughly 10% more of them were getting chemo after the change. Right? Fees went down, more chemo. Now, the usual instinct is this is probably a bad thing, induced demand and so forth. Oh, well, I skipped over it, but you can also show that if the fee change causes a big change in income, that the effect seems to go the opposite way of the fee change. That's what I've been showing. If it causes a small change in income, then it goes the direction of the fee. So if a small change in income, fees go up, physicians do more of it, and vice versa. So here, there were more patients getting chemo, but physicians started to treat them with agents whose relative price went down less. That's what showing. And unusually, after this change, mortality went down among lung cancer patients, among the elderly. There is some discussion in the oncology literature that oncologists were undertreating the elderly. This is not quality of life, you'll notice. It's just mortality. But still, we thought this was very interesting. There's a third study. We haven't heard much about geographic variation in prices this morning. There was a mention of urban-rural in the first panel, but I think it's fair to say that how Medicare varied fees geographically was rather haphazard early. Some would say it still is. Basically, to get political implementation in the 60s, Medicare let state medical societies decide geographic areas for Medicare geographic adjusters. CMS changed that in the 90s. It moved counties around. Fees changed, not a whole lot, basically a range of -4% to +4%. And that was studied, and lo and behold, now a big positive change with fees. Every 1% change in a fee increase, elasticities went up, or the amount went up 1.5%. So those are three pretty clean, in my view, natural experiments on fees. all of them show that fee changes matter to what is delivered. They do vary in the direction of the sign. The first two, fees go down, procedures go up. The third one, fees go down, procedures go down. Or services go down, I should say, not procedures. I want to talk a minute about joint costs and why a 100% fee-for-service system is so difficult to manage. So Peter's going to talk about practice costs, but the basic idea here is that it varies across specialties, but on average around half of physicians' revenue goes to the physician as net income, and around half goes to so-called practice expense. Now, some of those practice expenses are what economists call joint, meaning that you can't allocate them uniquely to a given service. So if the physician is paying rent for their office space, that's going to have to get reimbursed, or the physician goes out of business. But it gets reimbursed by basically spreading it around to various CPT codes. And that's basically an arbitrary allocation, and it means that, the slide says, setting aside the physician's time issue, the physician can always earn more income by doing more, because the add-on for those costs in the fee is going to exceed the cost of doing the service. It was rightly said this morning that fees for services aren't reimbursed. There's less of that. But so the physician, for the services that are reimbursed, the physician can basically always earn more by doing more. And therefore, what I've been pushing for longer than I would care to contemplate now is what economists would call a two-part pricing schedule, which is a somewhat jargony version of the medical home, or what people were saying as paying a per member per month charge with a fee on top of that. Because if we worry about joint costs being allocated to services and therefore giving an incentive to overserve, if it's a pure capitation, in theory, we ought to worry about incentive to underserve, since marginal revenue is zero. So somewhere in the middle sounds about right, and I think that's my last slide. Oh, well, just in case you fell asleep at the beginning but woke up by the end, there's the takeaways again. Okay, thanks.
Apparently not, right? Do I know what to do?
I don't know. Do you know?
I'm going to see where the slides
Want to
are.
do just talk again?
No, I could do that, but panel 3 slides, I think I got it. So
It's not that kind of technical.
it's
That's
not
the
that kind
problem.
of technical. So where are the slides?
Are we?
No,
oh,
no,
so we're still
no.
on.
It's the other one.
Keep going.
Steve's not here.
That looks good.
There we go.
I'll try that.
Yep, sorry about that.
That's all right.
Stepped away for a second. All right, they should be coming.
Thank you.
Okay, thank you. So when we were organizing this program, we decided that we wanted to have a session on research. And I think we basically thought about it. It was kind of forgotten research. Paul pointed out that, this morning, that this is a scientific approach to determining relative values. And there's 3 components to the relative value scale: work RVUs, practice expense RVUs, malpractice RVUs. No one got assigned the task of talking about practice expense or about malpractice RVUs. Peter's going to talk about practice expense, and I'm going to talk about work RVUs. And just to kind of remind people what you heard this morning, there's several components to work RVUs. The key focus that I'm going to be staying on today is time, but then the other components: technical skill, physical effort, mental effort and judgment, stress, that all comes into what people call, what Paul alluded to this morning, the intensity of the service. And that's the core concept behind the intensity and time are the core concepts behind the work RVUs. But think about work RVUs or any service in fee-for-service. What are you actually paying for? What are you actually valuing? So the unit of service becomes a fairly important concept when you think about how to value services within a relative value scale. So I'm going to touch on issues related to some of the CPT codes, global surgeries of different lengths for services, and then composite services of a specific duration. We've heard some people talk already this morning about the chronic care management code, so that's what I'm going to get into. So the first thing to ask ourselves when we think about work RVUs is time measurement accurate? We have time and intensity. Intensity we really can't observe, but we're going to see it's analytically important in a moment. So is time measurement accurate? Why is that an important question? Well, time explains 70 to 80% of the variation in work RVUs. So getting it right is important. And as Joe mentioned, you have indirect expenses that have to get allocated, these joint costs that need to get allocated, and time also factors in to the algebra that no one will have to see today, I promise you, that goes into how you allocate practice expenses across services. And the time measures that are used in assessing work RVUs, both by the RUC and by CMS staff, if there are errors in that time measurement, and if they're not random. Now remember, if everything is inflated by 10% in a relative value scale, that doesn't matter. But if some fees time is inflated by 10%, others 30%, and others by 100%, then that's going to lead to errors in both the work RVUs as well as the practice expense RVUs. And in the tradition of this conference, I'm going to give you my conclusion in advance also and say that the research shows that there appear to be errors in physician time that are not random across services. And changes, and what that means about changes in work RVUs relates to assumptions about this concept that the RUC is very familiar with, intra-service work per unit of time, intensity. And I'll come back to intensity shortly, because that's, as I say, going to be analytically important. Now I'm going to run through, as we said, there's forgotten research. I'm going to run through just some very fast results about time estimates. So early on, NAMC's data showed that Medicare times for visits were greater than survey times, about 9% different for established patient visits, 32% difference for new patients. OR logs suggested that 40% of surgeries were different from the times that Medicare was showing by about 30 minutes or more. Now, MedPAC examined this issue. Mark Miller, I think, talked about it this morning in the context of studying physician productivity and found that the fee schedule overestimates time spent by physicians in total. And if you think about just a little spreadsheet, you list all the CPT codes, all the number of times a physician does it, the Medicare assumption of the amount of time it takes, multiply those together, add them up, and some physicians are working about 200% of the amount of time that they actually work. So that was strong indication that time was overstated, and in fact, more so for specialties that are procedurally oriented. And some work that Katie and I did with some other people at SSS found a similar analysis and also showed that if you survey physicians just and ask them about times, that you also see that the Medicare times in the fee schedule are overstated. So more recent evidence, there were 2 independent studies that CMS sponsored based on the fact that MedPAC had decided that it was going to be possible to actually get better data on time. And so CMS sponsored 2 studies, one in 2015 that Rand produced, developing a model of work RVUs based mostly on non-CMS data, and it found that 83% of surgeries had shorter intra-service times, so that's a new concept, I guess, that we might want to define for anyone not familiar. Intra-service time is sort of, in surgery, this notion of kind of skin-to-skin time, not exactly, but kind of where you're actually in contact with the patient. 83% of surgeries had shorter times than existed in Medicare. Now, in 2016, the Urban Institute, RTI, and SSS collected data on physician time, a second study that CMS sponsored, for 60 services from 3 health systems. And for anyone who is concerned about the effort involved in collecting this kind of time data, I can assure you, it's not easy. And which is one of the reasons why we ended up looking at only 60 services. We didn't look at E&M services because E&M services are kind of heterogeneous. But what we found is that Medicare times were greater than 10% above the times we observed for these services, for 42 of these services, and they were 10% below for about 8 services. So within the procedures and surgeries that we looked at, we found evidence of higher fees, higher times in Medicare than exists. And in fact, if you look across the different types of services, for office-based procedures, we found that times in the fee schedule were about 11% overstated. In outpatient surgery centers, they were about 35% overstated. The inpatient periods, inpatient surgeries with global periods were about right. We didn't find, for where you go into an OR, those times in the fee schedule are on average about right. Imaging and other test interpretations were 238% of what Medicare is assuming in determining relative values. Now, this graph, for those who want to make sure that this is the research session, this shows a plot of intra-service intensity. So based on Medicare times relative to intra-service intensity using the empirical times. And because our times were lower than Medicare times, this is just the ratio of work RVUs to intra-service time. You see that intensity within the fee schedule is being overstated because times are being understated. So that, and none of this reflects post-operative visits, which I'm going to come to in a moment. And just to make this a little bit more concrete for the clinicians in the room, we selected 5 services that all happen to have the same intensity in the current fee schedule, an intensity of 0.07. So work RVUs relative to time, 0.07. And you can see that for some services, the empirical time we observed is greater. For treatment of a thigh fracture, it's about the same. For a laparoscopic cholecystectomy, it was a little bit lower. Again, a much lower for a joint hip replacement, and in proportional terms, much lower for an MRI of the brainstem. So anyone sitting there looking at these 5 services might think, should these all have the same intensity? That's a question to ask analytically. And but what we find is that when you look at the actual empirical times, you find that intensity is much higher for MRI of a brainstem than for partial removal of a colon or any of these other surgical procedures, where I think kind of intuitively you might think the intensity is in fact greater than interpreting an MRI of a brainstem without dye. So the reason intensity is an important concept, because if you believe the relative intensities are right, then in the fee schedule, then shorter times would imply much lower work RVUs for those services. If you believe the intensities are not right with the empirical time, then you would actually think that the work RVUs are correct. Okay, so wait, what happened here? Oh, I see. Okay, so I'm just going to talk quickly about unit of service, and I don't really want to talk that much about this, but basically what the results of our study, we reviewed with clinical panels the content of what people assume is occurring in a CPT code. And it really, the bottom line is that the services were not defined very consistently. There was more detail for some services than others, which tend to exaggerate certain time. Some of the descriptions that the RUC uses that go back, maybe 25 years, describe activities that physicians are no longer providing on their own. We've heard a lot about team-based care this morning. Well, team-based care may mean that there's less physician work in the service and more non-physician work. could be clinical, but still non-physician, but that would affect how RVUs are allocated. In some cases, pre-service work is included. In other services, it's not. And sometimes the vignette, which is kind of the more clinical presentation of the service descriptions, are not really consistent with the typical patient. But this is really the slide that the issue I want to focus on and maybe conclude with this. The unit of payment for global periods of surgery. So anyone that understands the fee schedule knows that this new excitement about bundled services really goes back to 1992. Because surgeons, especially for 90-day global periods and 10-day global periods, the number of visits that were provided just immediately pre-op and then post-op follow-up visits were all included in the fee for the service. But studies have shown that surgeons often provide a lot fewer visits than are assumed, resulting in unnecessary payments. So we know that you can carefully define these bundles, get a lot of input from providers, and still have bundles that are not accurately reflecting the services that are being provided. RTI did studies on this, GAO did studies on this, RAND did studies on this. In fact, RAND estimated that there would be about a 22% reduction of physician work by eliminating these, I guess what I would call phantom visits. And in 2012, that would have saved Medicare about $1.5 billion. Now, CMS recognized this. This was not a place where research was forgotten. CMS tried to address this problem by requiring separate billing for all the medically necessary visits, and they were going to do this by 2018. However, MACRA, that introduced the doc fix, got rid of the sustainable growth rate, stopped that payment change. Might have been one or two physicians in the country that contacted one or two members of Congress, and so now this payment policy change is really resulting in CMS, along with RAND, trying to collect data on visits so that they can improve the valuations. And then I'm just going to conclude by saying, there have been a lot of services added to the fee schedule that really are kind of duration-based services where you're seeing things that don't require face-to-face interactions with the patient during the service. And it's really part of the effort by CMS to address the concern that RBRVS does not adequately compensate for primary care. So you see just some examples. Chronic care management in a month they're now paying for, complex chronic care management, transitional care in 14 days after a patient leaves the hospital, and for higher complexity patients for 7 days. So you're beginning to see the fee schedule add codes. I know there was a debate this morning between adding codes or alternative payment models, but certainly CMS is pursuing the idea of adding codes like this. So I'm going to stop there and hear about practice expense RVUs.
Real quickly, while Peter's slides are getting set up, I just want to tell everybody that there's a bibliography available online that includes the citations for everybody's slides up here, and as well as some other materials that people who found this interesting may actually find those other materials interesting too, but maybe not. Anyway, that's available online at the same site that you went to register for this.
Okay, thank you. It's a real pleasure to be here to talk about practice expense, and it's not nap time. I'm going to try to keep you engaged as much as I can. But we've already heard that practice expense doesn't get maybe as much love as some of the other areas of the fee schedule, and you might be tempted to conclude based on that that's because it's not important, or maybe there's no issues with it. So I'll address each of those and hopefully disabuse you of those conclusions. So first of all, in terms of the importance, practice expense is serious money. It's almost half of the fee schedule payments, so over $30 billion a year. We've heard already that's just Medicare Part B. It spreads throughout the health system in the United States. So really we're talking about something that's a significant driver of everything from specialty choice to investments in facilities and service lines. So it's important to get this right. Now, I think the way that we do this, it's a very complicated formula. I'm convinced there's only maybe a handful of people anywhere that really understand exactly how it's done. Most of those people are probably here, but I'll just kind of quickly go through how this works, just so we're all on the same page. So practice expense is the cost of maintaining a medical practice. So what we do is we count some of the direct costs that can be more easily allocated directly to specific services. So we've got some equipment, we've got some supplies, and then we have some other things that go into the practice that need to be allocated down, and those are electricity, internet, rent, administration, those types of things. Another type of direct cost would be your clinical labor. That's non-physician clinical labor, so we count that as well. Here we see a very different type of physician office, but we use the same type of method. So we count here, we got some equipment, it's the chairs, we have some supplies, it's the Kleenex, and then we still allocate down the electricity. You're laughing, but this is really how it works. So let me give you a couple now concrete examples from the fee schedule. I copied these directly out of the fee schedule public use files. So first we'll start with colonoscopy, a common procedure. We estimate our clinical labor time down to the minute. So we know it takes precisely 83 minutes of intra-service time for a colonoscopy for nursing. We count all of our equipment. We've got the videoscope, the suction machine, the endoscope, disinfector, and we have an estimate for the useful life for these, a purchase price, the time it's used, again, down to the minute, and we can use those to calculate the cost. And then finally, the supplies, very detailed list again, ranging everywhere from the distilled water to the lubricating jelly, the shoe covers, the mask, the gown, the drape, the cap, etc. And there are estimates like this for, again, thousands of procedures in the fee schedule. You can look it all up. Back to the psychoanalysis, so there's a different type of count. So these are, again, real values. You have no labor under equipment. We actually do have the couch and 2 chairs. And we do have the tissues. They specify Kleenex, and it's 0.05 boxes that are needed per visit. So a very precise estimate, and some good conversion validity, actually, between the Sopranos and the fee schedule. So possible one has covered the other, copying the other. The direct cost data come from expert panels. Currently, this is the Practice Expense Subcommittee of the RUC. They do some data collection from specialists out in the field. They use a reference procedure in order to value new procedures and update procedures. There's been various incarnations over the years, but that is the method we use. For the indirect costs, we have data from a survey, the PPIS, which was sponsored by the AMA. It's about 10 years old. It used a sample of self-employed practitioners and some non-physicians. There's no plans to update that. And CMS actually calculates this for a fairly long list of different types of specialties. They're not all covered in the PPIS, so there's some cross-referencing that happens. Finally, there are 2 sets of practice expense RVUs that are calculated. There's your facility-based and your non-facility-based. And there's different costs there. We heard a little bit earlier about the site of service differential. And so what I want to focus you on here is just a recognition that physicians are compensated, even when practicing in a facility, for their practice expense of maintaining their practice separately outside the facility. So if you're doing a procedure in a hospital setting, there's an assumption that you still have staff and an office and rent and all those types of things, billing, et cetera, that are in an office. So for colonoscopy, that's a difference of 6.7 PE RVUs if you perform it in a non-facility setting versus 1.94 to cover those office costs if you're actually over in the facility. The valuation approach is too complicated to go through here, but let me just point out a few of the salient points here. One is that it works on allocation of direct pool. So although we count all those precise things, that's just to allocate the total pool. It's all budget neutral, and it produces only relative values. So we're only interested in not the cost of Kleenex per se, just how much Kleenex costs versus the endoscope. A second point here is that there are specialty-specific adjustments that go into this. So we recognize the fact that different types of specialties have different costs of running a practice. They have different types of practices. And then finally, the indirect allocation. Joe, I think, mentioned that this is pretty much arbitrary, which is true, but the way that's done here is on the basis of your direct PE. So if you have more equipment and supplies, et cetera, you have more practice expense, more indirect costs. And if you have more work, you also have more practice expense. So it's not just the time, it's also the intensity. If you are doing a more intense service, that probably requires more electricity and rent and so forth. Okay, so on to some of the issues and possible policy responses. So these are just, at a very high level, a few categories of different types of issues we're facing. One is the accuracy of these inputs, both direct and indirect costs, and also how do we keep those up to date. A second is false precision, which I think came up this morning. Do we really believe that we can estimate the cost of these things down to the individual minute or the individual unit of, to the hundredth of a box of Kleenex? The system is engineered for things that are easily counted. So how do we really believe in those estimates? What can we do about that? Third thing is the facility/non-facility site of service differential. Practice arrangements are changing, and are physicians really maintaining their office still? And the final thing is that there are other relative valuations in Medicare for different services. Those exist through the OPPS, which is a payment system for hospital outpatient departments and also ASCs. And isn't it a little bit problematic that even within Medicare we have different relative valuations for the same services? Never mind the absolute difference between site of services. So I'll go through each of these three basic categories of policy responses, starting with, could we update the inputs that go into this? So the PPIS is 10 years old. It's not representative of current practices. Isn't it time to update this? There are other existing surveys out there that collect some information about what it costs to run a physician practice. And there was a nice article in Health Affairs about a year ago that went through this and concluded that although you can draw some information from those surveys, it's not going to replace the PPIS. We can't just swap something in. So we might be able to draw some information from those as a patch. We could also go out and field another survey. It's not the easiest type of survey to do, especially if you want specialty-specific data. You need a pretty large sample size within each specialty. You're collecting a lot of detailed data on costs. Physicians don't have a lot of time to answer surveys like that, and we're trying to do this right now, so I can speak from personal experience. It is possible. So it's difficult, but it's not impossible. So we could do it. This morning, I think Mark Miller also mentioned the recommendation of, hey, maybe CMS should just pay some practices to just be monitored for their work. And if they do that, you might as well do some cost data collection for practice expense as well. You've got retail stores that are out there that are tracking everywhere that every shopper goes in the store, where their eyes go. Maybe there's some type of technology we could put in some physician practices if we're really thinking out there about a way to collect cost data in a way that's continually updated. I don't know if physicians would be crazy about that either, but. A second category would be to adjust this facility adjustment. So it's probably time to collect more information about what practice arrangements look like. That's all right, they're not that important. I can still see them. Recognizing that it's not as simple as a physician has an office and every once in a while goes over to the hospital but still is maintaining the separate office. Given the fact that we're seeing more and more hospital-acquired or hospital-owned practices, we're seeing more and more physicians that almost exclusively practice in a facility setting. So what is the true cost, again, of just maintaining a separate office for facility-based services? Yeah. No? Good. Okay. And the final category is the most important. So this would be, is there a way that we can re-engineer and simplify this valuation approach? And this starts to get into some of the broader questions that we've already been discussing today about, do we want to keep on investing in this fee schedule as it's currently structured, or do we want to consider a restructuring? So there's everything we could do here, from some pretty simple tweaks to to more complete reimaginings of what we could do. So one example of a tweak in the proposed rule for 2018 for the fee schedule, there was a proposal. There's a proposal to address the fact that there's some services that have very low direct costs. So think about that psychotherapy service. The direct cost for there is the Kleenex and the chairs, and we're using that as a basis for allocating all of the indirect costs as well. And what that leads to is a 72-cent cost difference estimate between the facility and non-facility setting. So they're saying for a physician to provide that service in a non-facility setting only costs them 72 cents more than if they were in a facility setting, which is also getting paid. So CMS said that's probably not right. So for this, we're going to set a floor. We propose a floor that's based on the most common type of E&M service. So that would be one simple type. One step further would be something that Katie and Steve simulated a few years ago in a report for ASPE. So this would be looking at the indirect allocator. Is there a better way to allocate it? I can take it from here. Thanks. I mentioned before it's now done on work and direct PE, and it has a specially specific adjustment. Well, perhaps instead of work, which factors in intensity, maybe the better unit would be time. And maybe it doesn't make sense to have those specialty specific factors adjusted. We've been paying certain specialties more for the cost of maintaining an expensive practice. They turn around and invest that money in the practice, which makes it more expensive. So there's some endogeneity there that perhaps we should think about removing. So they looked at a simulation of what it would look like if we valued practice expense in the fee schedule, taking those pieces out or changing those pieces. And that result was generally you would increase payments to most primary care specialties by about 6%, and then there'd be a corresponding decrease to most specialists. Okay. Because it's all a zero-sum game. So you increase some and it has to come out of somewhere else. And then finally, maybe we could do something completely different. And the sky's the limit here, but one idea would be, could we use some of this information from the outpatient prospective payment system? So there is a valuation methodology that's used in OPPS to get relative values for services. It is based on hospital cost accounting through cost reports and analysis of claims, and it leads to different relative valuations for the same services. So could we either use that to identify misvalued codes, or could we use that to set some bounds around some of the relative valuations around services and get to some convergence in methodology, at least within different Medicare payment systems? So in summary, although practice expense hasn't gotten a lot of love, I don't think that's because there's not some improvements that we could make there, and I think it's extremely important that we do that. We just need to decide whether we want to focus on investing in improving the current system, or if we want to perhaps start with a re-engineered approach and then think about new ways to measure the cost. So thank you for bearing with me through that. And,
So first of all, Peter wins the prize for persevering under adverse conditions, I say. And I was actually really impressed. So right now I want to, before we open up to, there's several steps before you guys get to ask questions. And I know you're dying to ask about the Kleenex prices. But first I wanted to see if Antoine has anything he wants to add, just from a sort of process or technical nature as you guys grapple with similar issues in Canada, or is it really different, or does it sound kind of familiar, or something else?
It definitely sounds familiar. That's one thing. We've been trying to figure out what's the cost of these Kleenex and other furnitures in outside the hospital, actually. And what we came up with maybe 20 or 25 years, I think it's more than 25 years ago, is a percentage of physicians' earnings. So when you are a physician, you're working in a hospital, let's pretend your salary is $100 or $100,000, for instance. When you're out of hospital, that salary will be increased by 33%, more or less. So you're going to earn $133,000. The thing is, that was the earnings for physicians 30 years ago. So as the earnings came up to what we have now in average for overall specialties, close to $400,000, $350,000, $100,000, the percentage of these Kleenex didn't rise as on the same trend. So Kleenex are not nowadays 6 times what they cost 20 years ago. They are more expensive, but they're not 6 times. So what we're seeing right now is doctors getting a very, very strong appeal for out-of-hospital practices because of this percentage that now they can put in their pockets, since there has been no evaluation of that cost, exactly what you were describing. There has been nothing to evaluate that for the last 30 years, so we have no clue, and hence we are just paying $100 a box of Kleenex, more or less.
So I also now want to give everyone else sitting up here a chance to either add something they wish they'd said or ask each other something that came up as they were listening, but maybe not. No. We're going to ask Peter about his mad skills to talk through that later. So I get to ask questions first, and then you guys get to. I wanted to first ask, we hear there's a lot of grumpiness about the fee schedule, I thought, this morning. And I wanted to sort of reflect back as someone who has spent time on Paul's notion of as a scientific, there's data, we do a lot of math, as you guys have heard. Are there some other features that this whole architecture has given us that maybe supports things that aren't these problems? Like some of these other payment policy things that Bob mentioned. We had the bonus payment for primary care for 5 years or 4 years, or other things like that. So does the architecture support strategies for reaching other policy goals, even if some of these mechanical problems continue to vex us? And maybe they have to vex us no matter what. Even if they were better, they may still be vexing us. So are there some strengths to this architecture that these technical problems maybe don't acknowledge or let us reflect on? Joe, turn that thing on. There you go.
Compared to what other architecture?
You tell me.
Well, as I said in concluding, yeah, if I think a mixed system with some fee for service component and some per member per month component would be a better system, but you could incorporate what you're talking about in that kind of system as well.
So in your mixed model, but I still need a fee for service system. So do you have an alternative? Do you think the fee schedule serves your approach okay, or would you throw it out and do something different in your mixed model?
The current fee schedule?
Sure.
I would throw out allocating all the indirect costs that Peter started to talk about, and then costs that were directly associated with specific service. So the gel for the colonoscopy, I would allocate to the colonoscopy.
So you would do the direct. You would keep the direct. You would keep working directs, but then take away the indirect allocation.
Correct.
And say that the capitated payments.
Correct. I mean, there's still the issues that were raised this morning about what is the service and how much bundling is in the service. That's a big unopened issue.
Fair enough. Does anybody else have?
So I'll make a comment that relates back to something Joe said and that came up earlier about the urban-rural issue and the geographic adjustments. So one of the reasons that I got into the Medicare fee schedule at the beginning of this process is that I was involved in the development of the original geographic adjustment factors to adjust fees across the payment localities. And it was very clear that while I was taking a nice labor economist, compensatory wage differential approach to thinking about this, there might have been some people in Congress that were thinking about this is an opportunity to raise fees in rural areas and lower them in urban areas, or at least compress the difference. So there's no question that the architecture related to the geographic adjustment factors gave people that policy lever. And so that, it went from the fact that we thought there was X amount of variation to the fact that it was implemented as 1/4 of that variation in the adjustment process. And then over the years, there have been floors put on the work RVUs, floors put on practice expenses, and all of those things allow the people making the political decisions to shift dollars around geographic areas. So that's a policy objective, whether you think it's a good one or a bad one. That's certainly the architecture allows people to do that.
I would say it's an interesting question. I think we still need to understand the costs of providing these services. Maybe I'm too locked into the current way of thinking, but I think the underlying idea of a resource-based payment is a good one. And if we're going to have this administered pricing system or some variant of it, I can't see a way around collecting data on costs to do that. If the unit of payment is partly capitation, we need something that's at the capitation rate. And unless we're going to get some kind of other way of setting that price, I think it's important to understand the costs. Listening from the other countries, it seems like maybe there's some similar problems, maybe in different directions. So in your case, the costs, in our case, we're pushing people towards hospital-owned practices. And in your case, people are staying out of the hospital. But It's the same fundamental dynamic that's pushing it. The things I wonder about, I have a good way of doing this, but is there a way to get more of a market signal to set some of the prices? So for at least some types of things, is there some kind of competitive bidding we can do or get a price signal? Or is there something similar to what we've heard about, say, in France, where we could set up at least a negotiating dynamic that gets at prices better than the way that the RUC is doing it? It seems like it was intended for the RUC to do that, but hasn't ended up working that way.
So Joe, can you address, thank you. Can you address the question about how you want to set your capitation rates for your partial capitation?
I would do basically a risk-adjusted system. What percentage should be in the capitation and what percentage should be in the fee, I think, is going to require some experimentation. There's also the administrative cost of doing a fee system, although if I'm running a medical organization, I probably want to know what's going on inside the organization, so I probably need to collect data on exactly what my physicians are doing anyway. But I don't have a fixed notion of how it should be divided between the capitation and the fee.
But how do you get regardless of?
I'm with Peter. I would have the fee as ideally right around marginal cost.
Right, but the capitated part, how do you get the capitated rate?
Well, it's going to depend upon how much I want to pay, in part. I'm not wedded to a, quote, scientific way of getting that.
So Peter actually sort of guessed at one of my questions, that listening to everybody this morning, and as a math guy, this is tough to say, but one of the things I kind of started wondering this morning, and especially some of the comments from Barbara Levy about the RUC, was at the end of the day, is in all of these countries, and in our own fee schedule, is this inevitably sort of a big negotiation? And so maybe we're overly fixated on the notion that it's science. We've talked about false precision and too many decimal points and how many Kleenexes. But at the end of the day, maybe it is about a kind of a complicated dance among a bunch of stakeholders who end up just sort of settling on seems to be okay. And then we have to worry about what are the signs that it's not okay and we haven't got the negotiation right. So I'm wondering if you guys can kind of quickly do a thought experiment with me that you didn't know I was going to ask you about, is to kind of think about what you talked about today as sort of a set of negotiations, like just a mechanism for a bunch of negotiations. And is the issue more about who's involved and are we having the right, is it the right game for that conversation versus do we have the number of Kleenexes right? Does that kind of make sense, my question?
It makes sense conceptually. It's hard for me to figure out how that works in the U.S. in the terms of who's negotiating with whom.
Well, I'm just positing that's what we're doing. I'm just positing that's really what we've got.
Who is we is the question.
Everybody in the room.
Oh, everybody
and my
in the room.
mom, but she didn't know. Like the whole system. Maybe what we really have is a big negotiation, right?
Yes,
and we
but
do it through these different mechanisms, and we do it through common periods, and we do it at MedPAC, and we do it, through the RUC.
But my understanding of the foreign system is basically the physician. There's an umbrella physician organization that's negotiating as a unified entity, and that's what's hard for me to imagine in the U.S.
Fair enough.
So thinking about the mechanism that we do have in place in the U.S., so as I said, if we get physician time is overstated, but we think the relative work RVUs seem reasonable, then we have intensity very wrong in the current fee schedule. The reverse is, if time is overstated, but you think, the new time implies intensities that seem reasonable, then work RVUs are very different. And I guess, as much as I've thought about this from a data standpoint, I don't think you're going to get around the fact that you're going to have some clinical judgment in here. I know there are many people in the room who are, not fans of the RUC. I'm probably included in that group. But somehow, whether it's, the physician associations in other countries or some sort of a physician advisory board, I personally would think that it would be better to have a sort of an independent physician advisory board recruited by CMS, but somehow you're going to have this professional judgment in here. but I think the objective data shows you where the problems are. Do you believe that interpreting an MRI of the brain is as intense a service as partial removal of a colon? I think those are the kind of questions that the empirical data raise.
Yeah, I would just add that I think it would be, first of all, I agree with your take that it is ultimately, it is kind of a political negotiation now of some type. And it's on the basis of some very technical, hard to understand algorithms that go into valuing this stuff. So I feel like if we could do what we were talking about this morning and get it down to whatever the right number of codes is, it gets a little easier, hopefully. At least if it's more transparent, I think you could have a better negotiation. And a problem now, if you make a change, a certain type of change, I don't think anybody can really predict what the effect would be until you see, run the numbers and see and say, that's politically unacceptable. And there must be a better way to run that negotiation or that process.
And that's my last question before I open it up, which is stability. And one of the things, like I've been involved in a bunch of the CMMI models in different areas. And one of the things that different specialty groups talk about is things that they view that the rates can change crazy year to year for certain services. And they will happily buy into some kind of a more prospective fixed thing if it's more stable. And so one of the things I'm wondering about you guys is things that we want to fix in the short run versus maybe there's a better model, except for who knows, it's a bunch of experiments versus, and I feel like I like all that, but I wonder how much turmoil and innovation the system takes before everyone just like explodes or something. So I'm just trying to figure out how do we balance, how do we learn, how do we innovate versus how do we undermine any sense of stability and buy into the endeavor broadly. Does that make sense?
Okay. Well, this is, thank you. I interpret this as part of a question about how society deals with technological change more broadly, whether it's robots or whether it's Chinese manufacturing firms, that goes way beyond medicine. Medicine is perhaps more difficult because there's been such a huge investment by the physician in human capital in terms of the length of training, learning a particular set of skills, particularly since we're so specialized. If I'm doing GI person doing colonoscopies, and the technology were to change to virtual colonoscopies, I have a problem. So I think I think the stability you're talking about is actually a small part of the overall issue of stability. There's no easy answer to that problem. We clearly want better technology if it's better for patients. We tolerate the kind of dislocations that causes in general.
All right, questions? Her microphone works better than mine.
I have a question for...
Can you identify yourself?
I'm Living Kai from Office of the Actuary, CMS. I have a question for Dr. Newhouse. You mentioned 3 studies that studied the volume response from physicians to fee changes. And I think you had a bullet point on your slides that seems to summarize your thought on this issue. But unfortunately, I missed it. So I'm curious of your thought on that issue. And also, more importantly, based on the historical evidence of the volume response, I'm wondering what you will think about the volume response when physicians are moving into the MIPS and APMs, how they will respond to the bonuses and penalties in the new system.
I haven't tried to look at that last question, but so the main point I wanted to get across with those set of studies is that fees do matter, or the level of fees matters to how patients are treated. and which sets up all of the other questions we've been talking about in terms of trying to get to the fee schedule or type of reimbursement system that we want. And then the subsidiary point was that the theory is that the effect of a fee change can have a positive or negative effect on services supplied, and we see that in the studies. Two of them come out with a negative effect, increase in fees, decrease in services. One of them comes out with the opposite, increase in fees, increase in services. And I don't know that a general statement can be made about the MIPS system. I certainly haven't tried to look at it.
Yeah. One thing I would say about the volume response, I think it's consistent with the studies that Joe referenced, and some work that I've done also, is that the idea that there's a uniform volume response for all services, which is something I think that has been assumed, in various analyses, either at CBO or OACT, is probably an oversimplification. That it's a complex system, and the conditions for which, in Joe's context, the income effect or the substitution effect tend to dominate, are going to vary across types of services. And I think that that's just analytically something important to keep in mind.
Yes, you may, Bob.
He's probably not going to like it. We're using so much economic jargon.
No, that's not the problem. So is the conclusion that you cannot modify fees to achieve? Okay. So my understanding about Japan is that they actively looked at fast-growing services, and whereas in the U.S. it's a screen for deciding whether the resource costs might be wrong, in Japan they actually looked at MRIs. They dramatically reduced the fees over a number of years, did not see an adverse effect on volume. Volume went up, but not at the same rate, and consider that to have been a very successful implementation of a price change to achieve a policy objective of decreasing costs for unnecessary MRIs. Can we do something like that, do you think, in the U.S., in the RBRVS, to add a explicit component of changing price to affect volume?
Well, that's actually one of the categories called out on the potentially misvalued services.
But what we do is we say that those are services worth looking to see if the resource costs are right. What they're doing in Japan.
The assumption that if you reduce fees, you will reduce volume. And both of what we just said was you can't necessarily make that assumption.
So the question is, so there's nothing you can do in that area,
Well,
or do you do it very carefully?
No, you may just have to feel your way along.
I mean, another example, which I don't know that you've looked at, but a natural experiment in the U.S. was the Deficit Reduction Act of 2005, which
that was the cancer chemo example came from.
Okay, but it also had an effect on imaging services, and the GAO then looked and found that prices were reduced 12%, I believe, and volume kept going up, but not at the same rate. It seemed to be a very good policy result. In years later, volume is still going up, but at lower rates than they were going up. I think that's a success story. And I guess my question to you is that sort of a one-off, or is this something that could be considered as part of a reformed fee schedule to more actively try to build in behavioral responses to fee changes as a way of establishing a fee schedule?
Let Joe answer first, but I had an answer.
I agree with that. As I said, our cost estimates produces actually.
Yeah, what I was going to say is that the services that were reduced in Japan and the high-end imaging that was reduced here are distinguished because a lot of the expense of producing those services is practice expense. So it doesn't run into the income and substitution effects to the degree that, say, a visit would.
Add to Bob's question, which is a question to all of you, but Bob as well, since he's a physician, would you wish to suggest that policy should be made only on the impact of a fee change on utilization without considering the question of whether it has anything to do with appropriate utilization in making health policy?
Certainly not, although reimbursement per se or the fee level per se is one tool for that purpose.
So much about
His mic's not very friendly.
No, very, no. The short answer is I don't know about that, but we do obviously have payments for that are various quality incentives, which is where I think this question would go in a reimbursement scheme.
Well, just on that point real quick, when the fee schedule was implemented in the early 90s and PPRC, I was at PPRC, and we introduced the practice expense methodology that's in effect now, and we introduced the notion of a site of service differential. And when we first started talking about it, one of our commissioners, who happily I don't remember who it was, said, well, this is absurd, because if you price things in both settings, you're going to be saying you could do bypass surgery in your office. And I said, is that really what we're saying? Like, can't there other factors that dictate whether what you do or not? Like, just because we actually didn't publish a price for cabbage in an office, just FYI. But even if we had, it didn't mean someone had to do it, right? So there's this question's been there all the time, and that's kind of what I was alluding to earlier this morning about CMS can't tell doctors how to practice medicine, and it's tricky what that ends up looking like, right? And so it becomes a kind of a hard conversation about what's priced versus what should be done. And there are examples of things that are still priced that probably most clinicians looking at it would say, they really still do that to people? Like, that's not a thing. Like, they shouldn't do that anymore. And yet it's really hard to prune the Christmas tree, right? And so I think that's a tricky business about like what should be there versus the more benign, neutral sort of hand behind it. Does that make sense?
So in geriatrics, we have a saying that when you lose money on every case, it's hard to make it up in volume. And the point of my saying that is to ask whether the behavioral responses to changes in fees might have to do not only with the direction of the change, but where that places the fee in relationship to the perceived work and costs of providing the service. And that may be a factor. I certainly think that would be a factor in determining that. I do have one question that's at the RUC and in the fee schedule in general. We try to, and I'm talking specifically about physician work, we try to evaluate the work for the typical patient. Well, what is the typical patient when you're talking about E&M codes that cover the whole universe, and how can my patient as a geriatrician is an 82-year-old with 4 chronic conditions, and a dermatologist has a totally different typical patient? And this is a problem. And then another problem with it is, I would argue that the cost problem in general is not necessarily related to the typical patient. It's related to the atypical patient, who is the very high cost patient. And it seems to me, for primary care doctors, the more complex and difficult the patient is, the poorer an economic prospect that patient is, because it's going to take a lot of work, and the typical patient payments don't compensate appropriately for that. So I wonder if you'd comment about the problem of the extremely high cost or complex patients, and whether we should tweak the system to take more account of that.
Well, in the capitated Medicare Advantage system, we effectively do. The HCCs account for that. Right. And so that fits nicely with my 2-part pricing kind of scheme. notion.
But I mean, in terms of the notion of setting RVUs at the typical patient, I think the idea behind that is if you can define typical, and I know for certain services, typical is harder to define than others. You're going to have some that are harder than typical, some that are easier than typical. How that's distributed for any given physician is very, very hard to determine. I think this issue, though, of the visit and the heterogeneity within the visit, I think this really comes down to something that I guess I would characterize, and people may take exception with this, as kind of one of the original sins of RVRVS, and that's that we have a single visit code that's used by all specialties. And it's hard for me to conceptualize as a non-clinician that visit is the same service for all specialties. It's not. But I think that this notion that a service is a service and a physician is a physician was applied broadly across all visits. People may take exception with this, but I think that, the fact that you have some specialties, psychiatry, ophthalmology, that have their own visit codes, but for most specialties, everyone's lumped together. And I think maybe you pointed out, or someone pointed out this morning, that you raise E&M payments and specialists benefit as much as primary care doctors. So I do think that that's a problem, the heterogeneity of E&M codes, which is one of the reasons that we shrewdly, in our study of time, eliminated E&M codes, because we knew that it was going to be impossible to study.
But part of that's a problem of prospective payment, no matter what, right? So the whole notion of prospective payment will set an average, even if it's, pretend we could do it right, but any particular actor may not actually ever end up with an average, like a distribution around that average that makes any sense.
Typical may not be the average.
Well, fair enough, but regardless, no, but besides that, but I'm just saying prospective payment, it has that. So if you're as a practice, and I think about the early AIDS patients, and the few guys in New York and San Francisco who started treating the early AIDS patients, they didn't average out in a year, right? And so I think the prospective payment will always, at some point, like it may be worse here because of this problem, but generically prospective payment will always have that kind of problem.
And there are some, like I think for surgical codes, there are like some severe, higher severity modifiers, but I'm not sure how wide.
There's another.
What those
more
payment
questions. Sorry.
Yeah. So I mean, the kind of the bottom line is, if we're going to save the cognates, we got to find money somewhere, and so, if we're going to achieve income parity, which is kind of the name of the game, if we're going to get a workforce that's going to do what we need it to do, the money's got to come either from Peter to Paul, which is going to be painful, or from PE, practice expense. So the question is, how much can we wring out of practice expense? And I think the caveat here is that the people that have made the most from the PE fluff are really the device manufacturers and the people who make the Kleenex. Those are the guys that have figured out how to use the system to support a whole bunch of things that go into PE per se. So it's not so much physicians against physicians. There's a big issue there. But there's also the notion that others have come into the system, figured out how to work the system, and now we're at a crisis point because our workforce is starting to tank, and it's not just primary care, it's infectious disease, it's rheumatology. There's a lot of these subspecialties that are in big trouble, and we need an answer, and we need it really fast. I mean, we're talking within the next few years, because it's going to take us forever to rebuild what we lose unless we get something done. So the question to you on the panel is, how much can we wring out of practice expense to shift into physician compensation?
I will take that first because you said practice expense, although it feels like a loaded question.
No, don't take it personally.
Well, I mean, the answer, so it's a zero-sum game, so you could take as much as you want out. And it just needs, there's no wringing it out of some other pot. It is all budget neutral, and it's coming from, if you're increasing one service, you're decreasing every other service. There's a number of ways to do it. I mean, I would start with looking at ways to simplify so we're not counting as many things, to get away from the dynamic that you mentioned, which I also mentioned, which I think it's currently engineered towards things that are easily counted. And so if you got manufacturers of things that are easily counted, you can do that. I think if you were looking at broader categories of service, you'd get probably to a reasonable level of precision in costs for setting rates without encouraging, okay, let's tack on as much additional counted things as possible to game this counting system.
Well, and to be honest, CMS did do that, has done that, and Ariel can talk a little bit more about it if anybody cares, but raising the assumption about utilization rates on expensive radiology equipment, imaging equipment, that effectively reduces the unit cost, which is what gets thrown into Peter's machine, and that was a very specific effort at kind of taking away the importance of this really big pieces of equipment. And you can imagine there were some people who weren't big fans, right? So there are examples of trying to do that like that. In the back.
Hi, Carl Polzer. I'm just wondering why the assumption is if you're going to wring a little bit of money out of the healthcare system, it automatically would go to providers, not to consumers. And my question is about monopoly rents or excess rents over normal profit levels. Is there any of that in the government set prices for Medicare? How much? And is the government helping a structurally advantaged profession make these excess payments? You know, because of structural features like being paid by a commons, being paid by insurance companies where individuals don't suffer the full extent of their consumption, by restricting supply because they of licensure requirements, because they have a tremendous lobbying power, and other things. Asymmetry of information, you can go on and on. There's probably some monopoly rent. I mean, $400,000 a year, if they got paid $350, huh?
That's about 100,000 US.
I'm not sure that we have a very helpful response to that. Do you want?
More a comment than a question.
Yeah, I think that's more of a comment than a question. Well,
Yeah, I think we agree.
no, well, and then we understand your question pretty well, and I think that the fundamental question that you're asking at the end of the day, and it was mentioned in the international one, was whether or not there should be salary targets, right? In some of these countries we've talked about that there are explicit salary targets, and whether they differ for GP versus specialists and all of that, and that's ultimately kind of underlying your question. And we seem to accept as a society a pretty big difference and relatively high for everybody compared to other earners. And that's kind of a cosmic question, I think, beyond us today. But I think we all acknowledge your point, and it's clearly embedded in the way this is set up. There was another one over here. Victor, I think.
So while we're going to this, so the only thing I'll say is that, what we're really dealing with is kind of the access issue. I mean, you're saying if you pay physicians a little bit less, would you get fewer physicians? And I think that that's kind of an empirical issue. I mean, MedPAC's framework for thinking about their payment recommendations always is monitoring access. And even like Alan's question before, it's like Medicaid pays less in a lot of states, and fewer physicians participate in Medicaid. Now, there's options there, but it does become a matter of access. But paying less, you just have to monitor that.
As I understand, a lot of this panel, RBRVS didn't do very much for E&M services for reasons you've explained, Steve. The same is true in France, in my experience. The whole study that was done, nothing was done on EMS. But the French, as I explained all too quickly, did come up with a whole set of prices for different EMS, evaluation and management categories, as I think in Canada. So my question is to Antoine. In France, they arrived at these prices, believe it or not through science, not through technical studies, but through just negotiations, systematic negotiations, and out of the air. If I read to you the different prices for the different kinds of EMM services, I would like to see your reactions, but I couldn't give you any studies on which they were based. In Canada, can you describe how this is done, or in Quebec specifically with respect to evaluation and management services?
We're obviously a little bit like the French people, probably something in the blood, but for Quebec at least. As for Ontario, they're the very first who were able at some point to lower, just like you were saying at the rear there, to lower the salaries. They decided that the physician's income was too high, and this really is, it's moved not only by science, not only by studies, but really by public opinion. At some point, people get angry at the idea that a physician, even though studies are costly, and I'm not talking about Quebec, as I said, or Canada at large, but even though studies are costly, even though the stress is high, mental efforts, physical efforts, the technical aspects of it, at some point, too much is too much. In Quebec, everybody agrees on the fact that earnings of $400,000 a year for a specialist and $250 for a GP is already extremely high, and we're going on a new negotiation round right now. And everybody's wondering, are we really going to increase their income again? Or are we going to freeze that? Or are we going to scrap the whole thing and start all over again? How are we going to manage that? Because it's not, the population will not tolerate increases in these amounts that are already sky high.
Yeah, I listening to this panel, I was struck by a number of instances where the lack of dollars has very much limited the research and even the policies to deal with these issues. When Peter was mentioning we need a new study, it's been 10 years of practice expense. I remember 10 years ago how overdue that survey was. And I think it was motivated by the really bad data that was being collected by specialty societies to gain on the other specialty societies. But in a sense, it becomes relevant to, the whole approach of using science. If funding is going to be so constrained, maybe we even have to think about something that is akin to negotiation to address the really severe distortions we have now.
I think we're going to call it done. We're at the hour here, unless there's one more quick question. No? I think we're going to call ourselves ahead of time here, which is great, and we'll be reconvene at 15. Is that right?